pancreatic function. So the function of the pancreas. The pancreas is a vital organ with both exocrine and endocrine functions essential for digestion and blood sugar regulation. So the exocrine function, a pancreas produces digestive enzymes that are secreted into the small intestine by the pancreatic duct. These enzymes include amylase, lipase, and proteases. So amylase breaks down carbohydrates into simple sugars. Lipase breaks down fats into fatty acids and glycerol, and proteases such as trypsin and chymotrypsin break down proteins into peptides and amino acids. These enzymes aid in the digestion and absorption of nutrients from food. For the endocrine function, the pancreas contains clusters of cells called isolates of Langerhans, which secrete important hormones directly into the bloodstream. So alpha cells secrete glucagon, which raises blood glucose levels by promoting glycogen breakdown in the liver. Beta cells, which secrete insulin, which lowers blood glucose by promoting uptake of glucose into cells and stimulating glycogen synthesis. We also have delta cells, which produce somatostatin, which regulates the secretion of both insulin and glucagon. And then we also have PP cells, which produce pancreatic polypeptide, which regulates pancreatic secretions. The importance of the pancreas, so we need the pancreas to be functioning properly. It is critical for maintaining the normal blood glucose levels and efficient digestion. If there's dysfunction, it can lead to diseases such as diabetes or pancreatitis. So in cystic fibrosis, the CFTR protein defect can cause thick, sticky mucus to build up inside the pancreatic ducts, and this will block the release of the digestive enzymes into the small intestine. So to test for this, we would do a sodium and chloride measurement in sweat. In cystic fibrosis patients, there is a significant increase in the concentration in both sodium and chloride in sweat due to the defective chloride channels in the epithelial cells. This increase occurs in approximately 99% of patients with cystic fibrosis, and so this makes the sweat electrolyte measurement highly sensitive and specific for diagnosis of cystic fibrosis. So there is a 2 to 5 times increase in sweat sodium and chloride concentrations compared to normal values. And notably, there are no other medical conditions that can cause sweat chloride and sodium concentrations to rise above 80 milliequivalents per liter, which helps to differentiate cystic fibrosis from other disorders. The procedure for the sweat test. So the sweat test for cystic fibrosis uses an ionotrophoresis with pilocarpine administration to stimulate sweating. The ionotrophoresis involves applying a small electric current to the skin, typically on the inside of the forearm, and that helps to drive the pilocarpine into the skin. The pilocarpine is a medication that helps to stimulate the sweat glands, and that causes the skin to produce the sweat. So after the ionotrophoresis, a collection device, usually gauze or filter paper or something like that, is placed on the same area to help collect that sweat. And then the collected sweat is then analyzed primarily for chloride concentration, which is critical for diagnosing the cystic fibrosis. To ensure accuracy, the test is usually repeated for confirmation. And the reference diagnostic value of a sweat chloride level is greater than 60 millimoles per liter, and that is indicative of cystic fibrosis.